Welcome back. Thank you for staying with us here on KTN Prime. Allow me to say a big thank you to three gentlemen who've stayed with me since we began this bulletin. Professor Omwanzala, Virology and Immunology, CAVI, Institute of Clinical Research from the University of Nairobi. We also have Dr. Colin Stabu, Head of Vaccine Programs at the Ministry of Health. And we also have Professor Walter Jaoko, Professor of Medical Microbiology and Tropical Medicine. He's also the Director of CAVI, Institute of Clinical Research, and former Chair of the Department of Medical Microbiology at the University of Nairobi. Gentlemen, thank you for staying with us, because this is an interesting conversation, an important one at that we need to have about the COVID-19 vaccine. Professor Omwanzala, this is where I'd like to bring you in, because there's been a lot of concern about the vaccines that are out there. I mean, COVID has been here for under a year, and the concern that people have is how efficient is it? How do I know whether or not it will work? Do I know how long it will cover me for? Why should I take this vaccine?
Yeah, thank you, Linda. The non-pharmaceutical interventions that we have so far are not working in Kenya, and are not working globally. And what really is going to be a game changer to stop this spread is a vaccine. Maybe what the audience should understand that SARS-CoV-2, the virus, and COVID, the disease, started last year. But before this, in 2002, we had an outbreak of a coronavirus. And even if you go back in the 18th century, there was another outbreak of coronavirus. So somewhat quietly, research has been going on coronaviruses. So that when you see these inventions that have been quick, to be pronounced and come in, it is not that coronavirus research started in 2019. No, this has been going on for a long time. When you look at the platforms that we are talking about, mRNA platforms, these platforms have been there for decades. So really the information about the platforms, the mRNA, replicating, vectors, this information has actually been there. So the only issue was to understand this virus, to understand the immunology, get this work done very quickly, and it was done very quickly in the animal studies, and then begin human trials. So far, the Pfizer vaccine, 1,000 people are in phase 3. The Moderna vaccine, about 30,000. The Chadok vaccine, maybe another 30,000. And these clinical trials are enrolling at a very high rate. So as far as we are concerned now, the triggers that were done to look at safety and efficacy that came together and gave us between 70 and 95% were real. So for us, really, is not the question of whether these vaccines are safe. So far, the vaccines are safe. There are a few questions that we still don't know, but those questions are going to be answered as we go on. What I'd like to remind the audience is that this same problem was there during the Ebola vaccine. We had a vaccine that was authorized to be used during the emergency. We can now say that we are proud that at this point in time, we have 2 nice Ebola vaccines. So what is the only concern now is that we don't know yet, because the volunteers have been not followed for a long time, how long these vaccines will protect. But for now, we know the safety profile is good. We also know the efficacy profile is good.
So the efficacy, hold on, efficacy is okay, the safety profile is good, and you've mentioned that there are a little bit of unknowns. What are some of these unknowns, if you may?
The only unknown now is that as we do this in a larger sample size, we may find maybe some side effects that we have not noted at this point in time. Secondly, what is really critical is also for us to get to know, because we normally want to follow volunteers for a period of 1 year. That has not been done yet, but it is being done now to really understand whether this vaccine will protect us for a period of 1 year. So those are some of the things that are still unknown, but that is not a problem. So long as the safety and the efficacy is good, we shall continue generating more data And when you say emergency use authorization, means that as you administer this vaccine, you don't administer and walk away. You administer and continue following up these individuals to gather more data.
So basically, what
we are actually in a very safe ground as we speak at this point in time.
Okay, so basically what you're saying is you're going to learn as we go, and you're saying we're in a safe place. Allow me to bring in Professor Walter Jaoko. Professor, I had a conversation today earlier on with Dr. Gitahi Githinji, and he says, Linda, this is the thing. We should not treat this vaccine as the ultimate response to the COVID-19 vaccine, because we know very little about it. There are cases where it's been reported to be mutating. And he says, even if we get the vaccine, we still have to put in measures, we still have to put in place the measures that have been there, social distancing, put on your mask, just the basics. So from where you stand, the vaccines that are already being rolled out in the UK, plus, of course, what Collins was talking about, is this it from where you sit? Because I know you've worked with a lot of other vaccines from the study that you've done.
Thank you, Linda. It is true. What we are saying is that a vaccine is an ultimate tool in the fight against COVID, but it doesn't mean that we should keep away from the method that we're currently using to prevent transmission of COVID. So we are not saying that the vaccine is coming to replace all these other measures. And we must realize that the vaccine will take time before we have sufficient number of people given the vaccine. And we are still not even sure whether this vaccine will then be able to protect, to give us herd immunity. So at the moment we are giving the vaccine for individual benefit, but we are hoping that we are going to get sufficient number vaccinated and thereby contribute to preventing transmission to other people. So I totally agree with Daktari that this does not mean that we stop the practices that we are doing. There is a fear that you usually have, and it's not just for COVID, where people think that because they have a preventive method, then they can live lives that expose them to a particular infection.
Yeah.
It happened even with HIV. The fear was that when you get treatment, then people would start living lives that expose them to HIV. So that is something that we need to watch against.
Yeah, so because people say, I mean, the vaccine is already here anyway, so we can as well live our lives and we are protected. Listen, there's something you talked about, herd immunity. I know what it is. I'm quite sure a good number of the viewers do not understand what herd immunity is. So as you say, we need to vaccinate enough number to be able to have herd immunity. Explain that to my viewers.
So what happens is this. Once you've vaccinated a certain number or a certain proportion of the population, what happens is therefore that the virus would not be able to be transmitted easily. So in other words, that because of the reduction in transmission of the virus as a result of people who have been vaccinated, although you yourself have not been vaccinated, it prevents or reduces the chance of the virus infecting you. So what we mean, therefore, is that we have reached a certain level of immunity or a protection that even the people who have not been vaccinated are protected.
Okay, so we need to vaccinate at least 60% of the Kenyan population to get there.
Yeah, we need to vaccinate a certain percentage. It varies from virus to virus, but we hope that 60% will be sufficient.
Okay, I hear you. So one, Professor Omu says, we are good to go, we can roll this out. You're saying it's not the ultimate solution per se. The measures that have been there, we still have to observe them. I'd like to bring in Collins Tabu. Collins, so we've all agreed that it's important to have this vaccine. We need to find a way of getting as many Kenyans as possible to have this vaccine. But the two specific vaccines that are out there, the Pfizer, BioNTech, and Moderna, there are specific conditions that would mean a lot of logistical challenges in terms of moving it, storing it, and I know for a fact that is it Pfizer? You have to keep it under negative 90 degrees. How is the Ministry of Health planning to handle that, if at all?
So thank you, Linda. First of all, I'd like to say that the Ministry of Health is at this point in time in its preparatory activities, and it's well prepared to be able to handle the vaccines that we will be able to receive. While the Pfizer and the Moderna vaccines have negative storage temperatures, we have another range of vaccines that have positive storage temperatures of 2 to 8 degrees, like Professor said, that would be stored within our normal vaccine refrigerators that are cut across about 10,000 health facilities around the country. So we are ready to that extent. For the negative temperature storage, we can be able to manage the minus 20 degrees negative temperature storage down to our sub-county levels as it is now, and so we're ready for that. We're doing the mapping of our volumes and being able to do the necessary capacity strengthening to be able to manage that. At the central level, we can be able to manage limited volumes of the very negative temperature storage. But this is to say, as a country, our preference would be that will be able to fit within our cold chain system, our distribution mechanisms, right as the vaccine comes from the manufacturer and reaches the country, and from the central depots to the sub-counties, and then subsequently to the health facilities. Most of our supply chain is either minus 20 degrees or 2 to 8 degrees. So invariably, we are ready. And speaking about readiness as a country, we've gotten the biggest support from our ministry leadership in terms of setting in place the most efficient coordinating structures, just to be sure that for every week, almost on a daily basis, we cross-checking our levels of preparedness in terms of what was said earlier. What is our distribution channel capacity like? What is our storage capacity like? What is our human resource capacity like? Who are the health workers that are going to give these vaccines? We have them mapped out to the health facilities that then will be able to give them. What pattern would we use to give these vaccines? Would it be through the health facilities or on an outreach basis? So we have that being penned down. And then the other aspects of really just making sure that we have on board the community working with us the journey to really stop the pandemic.
Collins, hold on. So is there a specific strategy on how this vaccine will be given out? Because there are those who say, like the UK, they've started with the elderly and people who work in the healthcare facilities, healthcare workers. What is the plan by the Ministry of Health once the vaccine gets here? Who do we start with?
Yeah, so thank you. So we've done, we have a plan in place to be able to, first of all, start with the most vulnerable.
Who are?
But I would just like to put this into context before I get to the specifics of who these most vulnerable are. The considerations around who you start with vaccinating depends on two broad things. One, in terms of what the vaccine availability is. Do you want to shoot for a national vaccination of 50 million Kenyans, but yet you have 500,000 doses of vaccine? It means you have a prioritization process to say, I will start with these populations and then go on to the others. Number two, we need to be able to re-examine at what point we are within the pandemic. Do we have very few cases? Do we have sporadic cases? Or we are at the level of community transmission? For us as a country, we are at the level of community transmission, meaning the disease is out there everywhere, in every county, sub-county, circulating within the community. So if community transmission is the issue and we have limited vaccine availability, then we would be able to target the most at risk. And the most at risk in this case coming at the front line would be the frontline health workers, and then followed by maybe the elderly, also to speak, varied, of course, according to the availability of vaccines. Then the objective of starting with the most at risk is we really want to reduce the disease burden, and we really want to reduce the morbidity, the number of deaths that we have seen. Now we are at 1,500 associated with this particular disease. As we get more vaccines available, then we get to get to the next levels of risk, bring on board a concept of maybe, let's say, reciprocity, the people who are a bit more exposed, serving us in the front lines of COVID and who potentially stand a chance to spread it a bit more. We have our uniformed forces, we have our people in schools and many other people. So we'd move on to the next level of risk, depending again on the subsequent availability of vaccines. As we move on to then be able to roll out the vaccines, several considerations are made. Like I have shared, we have penetration to over 10,000 health facilities with 2 to 8 degrees temperature storage for vaccines. So if we have such a vaccine, then it will be able to go conceivably down to that level. So it means that then we train health workers that will be able to administer the vaccine down to that level. But if we have negative storage temperatures, then it means we may focus a lot more at the central levels around which we can be able to keep the vaccine viable. It'd be useless trying to pick a negative 70 degrees vaccine and trying to rush it down to the periphery, knowing that as you try to do that, it will lose its effectiveness or viability as you try to get it down there. So you really want to focus your resources where you have the maximum impact.
Okay, so let's work with what will give us the optimum impact. Professor Anzala, there's logistical nightmare in this. You have over 50 million Kenyans, and I was having a conversation with someone about this vaccine, and he said, Linda, when you're looking at the cost of this vaccine, you're not just looking at the cost of the vaccine, you're looking at the cost of the syringe that will be involved, you're looking at the cost of the people who will be involved in administering this vaccine, you're looking at, it's a whole team, it's a whole logistical thread. For you, what stands out in terms of distributing this vaccine when it gets here? What are the key issues that the Ministry of Health needs to focus on if we have to get this vaccine to as many people as possible?
You know, really the challenge, as I've told you, there are those three things: vaccinees, vaccinators, the vaccine, the vaccinators, and the vaccinees.
Yeah.
So really the choice of the vaccine has to be determined, very, very carefully, because this is an expensive product. It is a biological, and if you don't go through the process of picking and choosing something that you can distribute, as Dr. Tabu has clearly said, up to the lowest level, then you run into problems because you'll end up with a lot of waste. So the choice of what product we can actually be able to deploy in this country, I think the ministry is on top of things, and they will actually pick and choose. The second one then is where is the human resource?
Yeah.
Understand, Lisa, that our immunization of children under 5 must go on. So the next big thing is that you want to bring in this vaccine, you want to distribute, but you want on a daily basis to be managing to vaccinate a given number of people. So the human resource there becomes very, very critical. You may not use the currently available human resource because that is already taken.
Wow.
So that is another level of logistics that the ministry must look at very, very critically. Look at where we are with COVID, look at the issues that are going on with COVID, and realize that we shall be vaccinating in the midst of an outbreak. COVID will not have gone away. COVID will actually still be there. So we are again talking issues of protection, the PPE, whatever level. So all those things, Linda, are things that the ministry must actually be thinking of. And then at the end of the day, there are 2 dosages. So far, all the 3 front-runner vaccines are talking of 2 doses that are going to be given either 3 weeks apart or 4 weeks apart. Again, the logistics of ensuring that whoever you are vaccinating now must be able to come back again after 3 weeks or after 4 weeks. Again, a system of putting that in place to ensure that these people actually come back. And then, at the end of the day, we must begin to communicate and communicate now and have dialogue with the communities. There are a lot of skeptics. We work with Professor Jaoko very closely. We have done a lot of vaccines. There are a lot of skeptics out there. There's a lot of hesitancy out there. This is actually the time for the ministry to begin to communicate. And it is not communicating, putting in the newspaper. It is actually talking to me as an individual that this vaccine is good for you. And if you take this vaccine, it will protect not only you, but all the other people will be around you. But at the same time, we must continue with the other non-pharmaceutical interventions that are there, because COVID has not gone away. To vaccinate 1,000 people, 2,000 people, 3,000, 5,000, 11 million is not a walk in the park.
Yeah.
So this preparation, these things we are talking about, readiness, is not an easy thing, because as we wait for the product, this readiness in terms of training the human resource, communicating, getting to know, even if you say the elderly, how many are they in Kakamega? How many are they in Kwale? Where are they? How are we going to get to them? These are the things that we must begin to put in place. It's not like what we done before with childhood vaccines. This is a completely different ball.
And this one, you're looking for adults half the time, so it makes it even more complex. Collins is here in studio with me. I'm hoping he's picked up some of the issues you've raised. Professor Jaoko, let's talk about, I want us to debunk some of the reasons or concerns that people may have to do with the vaccine. Professor Anzala says you've worked together very closely with him, and there's a lot of hesitancy on whether or not people should take this vaccine. Address that in terms of why people need to take this, why they should not be concerned, why it may be our best option yet as we speak.
Yeah, thank you, Linda. Like Professor Zala said at the beginning, that actually a vaccine will be the game changer in our battle against COVID. Now, the problem we have in the modern age is that there is a lot of misinformation out there, especially in the social media and the internet, and a lot of it is based on lies. There are people, we have a very strong anti-vaccine lobbyists who intentionally misinform the people. And if you read some of the things that they say, even about the vaccines that we have given our children. The other day I was reading one of those articles where somebody writes and saying 60% of children who get polio vaccine develop mental illness. And you can imagine, I mean, we have vaccinated our children with polio vaccine. If that was true, you'd be seeing crowds of people with, with mental defects, which is, so it's obviously wrong. But because it is out in the internet and people cannot distinguish what is true and what is false, that has caused a lot of confusion. The other thing is this idea that a COVID vaccine has been rushed and therefore it is not safe. Yeah. There is no truth in that. So what has happened in developing a COVID vaccine, what has made it be developed quickly is that we have only expedited the process. All the processes that we usually follow in vaccine development have been followed. We have tested it in what we call preclinical studies, where you test it in animals first, and then you come and test it in human beings, and you do it in phases, where phase 1 you're looking at safety, and phase 2 you're looking at whether it's producing the desired responses that you want it to produce, and then finally, what we call efficacy phase, where you now testing whether what you're seeing being produced is capable of preventing somebody from becoming infected. So no step has been jumped. Everything has been done methodologically. But it is only that it has been expedited. It has been done more quickly. So there are a lot of false information out there. And my urge to Kenyans is that please don't listen to a lot of lies that is out there. Seek clarity if things are not clear, but be careful about the lies that is being perpetrated.
Okay, Collins and his team have a lot of work in their hands in terms of convincing Kenyans. Half the replies I'm getting from our big question whether or not Kenyans will take the COVID-19 jab is, I don't trust it. I don't believe it will work for me. I'll try and read some of them. But Collins, just respond to some of the concerns that have been raised by the other panelists in terms of how prepared is the ministry?
Thank you. Just before I go to that, and just to reinforce what Professor Jaoko just said right now about the nature in which the vaccines are being deployed, the process of development has been expedited. It doesn't mean in any way that the vaccines are less safe. The vaccines are safe. They've been found to be efficacious. And as we move along, remember each and every of them at one go is being allowed, or rather being allowed to be deployed. They are being evaluated globally. We will evaluate them locally. As they're being deployed, there's continued monitoring of safety. As they're being deployed, there is more peer review that has to be done right before that. As we move on at the ministry level, we've put in place the necessary preparatory measures to make sure that these vaccines are deployed. Like I did share before, we've done a mapping of our distribution channels. We have a pretty good idea how we're going to access the vaccines. Kenya is part of a global pooled procurement of these vaccines through what we call the COVAX facility that's being managed by Gavi and WHO and CEPI, to which about 187 countries of the world are members to. And this facility is in place not because we're not able to do it on our own, but because the global community has come together to assure that everyone has an equal chance to be able to access these vaccines regardless of their ability to be able to pay.
Good. Hold on, Colin. So what you're saying is that Kenyans will be able to access this vaccine whether or not they can pay?
Kenyans will be able to access these vaccines whether or not they can pay.
Who will foot the bill?
The country is putting in place measures to resource mobilizing to be able to avail these vaccines to Kenyans at no cost. I'll be able to say that a bit confidently. Number two, through that global pooled procurement, then we are assured of accessing vaccines at least for 20% of our population, at least more than 10 million individuals will be able to the outset get access to these vaccines. This is as opposed to a system where each country has to run on its own. So even the high-income countries are part of this global pooled procurement where the vaccine supply is being mapped across all those that need them, so that a country's inability or economic status should not be hindrance to that particular country accessing these particular vaccines. That's what it is. As we move on, again, like I did share, we've mapped out our distribution channels. We have an idea where and how these vaccines will be given out, and we're getting the biggest support from the ministry leadership, just pushing us to make sure that this is actualized. So we are ready for the rollout. We have a good idea about what number of health workers we have in place, what their capacities are, and what kind of training then they would need to roll out the vaccines, based again on the vaccine characteristics. We over time, and drawing from the engagements from the COVID disease as it is now, we over time have a pretty good idea about what the communication needs are, just to debunk the myths around this disease and the vaccine as well. And like Professor Jaoko said, it is not so much about taking the vaccine in place of the other preventive measures. The vaccine is coming to complement the other preventive measures in place. It's being deployed under an emergency use approval. Why? Because we need to stop the pandemic. We need to stop the deaths that are going on within the country as it is now.
That would be a perfect place to end it. And I let you speak on for a while because you represent the voice of the Ministry of Health. So you say we're ready. When this vaccine gets here, we'll be ready. We have plans in place. And Kenyans, the Ministry of Health is telling you, when the vaccine gets here, it will be free. They're trying to put measures in place to ensure that when it gets here, it will be free. That's good news, if you ask me, from where we stand. Gentlemen, allow me to say a very big thank you to all of you for being part of this conversation. Professor Omu Anzala, as always a pleasure speaking to you. helping us debunk everything about this virus and where we are as a country, as a global team just trying to fight this virus. Thank you so much for your time. Dr. Colin Stabu, who's been here in studio with me from the Ministry of Health. With that good news, you're not going to pay for your vaccine. Thank you so much, sir, for your time and for speaking to us on KTN Prime. And a very, very big thank you to Professor Walter Jaoko. It was such an honor hosting you for this show. I hope we can do this more and more again as we try to explain to Kenyans what is happening with the vaccine, with the virus as well, and the way forward. So a big thank you to the three of you. Thank you so much for being part of KTN Prime and indeed explaining to Kenyans and answering some of the questions that they do have. Okay, so having listened to the